March. Welcome to our March ADRC Advisory Committee. Glad to see you all. We are going to kick it off with housekeeping rules and then roll call. So I will pass it over to Wilson.
Good, thank you, Eli. Good morning, everyone. Happy Friday, happy March already. Just want to go over a few housekeeping items. So for those attending in person, please reminder to mute your laptop so we don't have any feedback. And then for those that wish to access closed captioning services, you can click closed captioning or CC on the Zoom toolbar. Today we do have two ASL interpreters with us, and they'll be spotlighting themselves. If you need any assistance at any time during this meeting, please email adrc@aging.ca.gov. In terms of for communications, for those attending by Zoom, we do ask for everyone to remain muted unless presenting or speaking. Chat is workable, but it only goes to the hosts and co-hosts. So if you send anything via chat, we'll bring it up to our chairs and then and address it as needed. For our committee members, you can speak by raising your hand using the raise hand function and then pressing unmute once called upon by the chairs to speak. For non-committee members, there will be an opportunity to speak during the public commenting periods. There's two of them, one in the first half, one in the second half. And when called upon, or to raise your hand, same thing via Zoom, raise hand function. If you're calling in by phone, it's *9 to raise your hand and then *6 to unmute once called upon. And I think that's about it. So I'll turn it back to our chairs, who's going to probably turn it back to me again for roll call.
Right back to you for roll call, Wilson.
Oh, dang, just like as I thought. Okay, so Wilson again with the California Department of Aging. Roll call, we have 19 members on the committee. I'll start off with the ILC, or Independent Living Center representatives, alphabetical order, starting with Carl Sigmund.
Good morning, everyone. Carl Sigmund here.
Perfect. Good morning, Carl. Next, we have Eli Gilardin from Marin Center for Independent Living.
And I am still here.
You are still here. Thank you, Eli. Next, we have Larry Grable from Service Center for Independent Life.
Present.
Hello, Larry. And next, we have Letty Zuno from Access to Independence.
Good morning.
Good morning. Hi, Letty. Next, we have our 4 Area Agency on Aging representatives in alphabetical order again, starting with Cindy Kaufman from the San Francisco Department of Disability and Aging Services.
Here.
Hello, Cindy again. Second, we have Elaine Clark from Napa Solano Area Agency on Aging.
Hi, I'm here.
Hello. Next, we have Joe Cobry from Passages.
Morning, glad to be here.
Hi, Joe. Good morning. And last but not least, we have Victoria Jump from Ventura County Area Agency on Aging.
Here.
Hello, Victoria. Next, we have 5 consumer caregiver representatives, starting with Andrea Dubrow. No, Andrea? Team, let me know when Andrea does arrive. Is that Andrea? Okay. Next, we have Cindy Soto. She does express her regrets. She won't be able to make it today. Next, we have Darlene Gee Mellicart.
I'm here. Good to see everyone.
I also help with submitting our bill petition letters and tracking legislation and our sponsored bills. And a current grad student, hopefully in my last semester at.
Darlene, if you don't mind muting, thank you. Next, we have Erin Crutcher.
Good morning, here.
Good morning, Erin. And last but not least, we have Tammy Harsh, and she does also express her regrets. Won't be able to make it today. Lastly, we have our long-term services and supports representatives, starting with Gabriel Rogan from the North Bay Regional Center. Team, let me know when Gabriel arrives. Next we have Helen Lopez. No, Helen. Same thing, let me know when she arrives. Next we have Kelly Takasu from the Alzheimer's Los Angeles.
Hi, good morning, present.
Hello, Kelly, good morning. Next we have Ramon Costelblanc from San Francisco State University. He will be attending in person but running late, so we'll introduce him later. Next we have Rita Syens from the ADRC California Executive Council. Okay, no Rita yet. And last but not least, we have Sherry Raisler from the Society for the Blind.
Good morning, everyone. Good to be here.
Good morning, Sherry. So that's our 19 members. Next, we have our ex officio members in alphabetical order based on acronym C4A, California Association of Area Agencies on Aging. Michael did mention that he was not going to be able to make it, so no Michael today. Next, we have CalVet, California Department of Veterans Affairs.
Hi, this is Sean Johnson. Pardon me, voice. I'm here on behalf of Deputy Secretary Roberto Herrera today.
Sean. Next, we have CCOA, California Commission on Aging.
Good morning, everyone. Carol Swartzlander here.
Morning, Carol. Next, we have CDA, California Department of Aging.
Hi, my name is Mike Rieger. I'm with the HICAP Bureau. I'm our MIPA, one of our MIPA leads.
You, Mike. And we do have Mark and Denise joining a little bit later today for our CDA updates. Next, we have CFILC, California Foundation for Independent Living Centers. And Brett and Dan mentioned that they will be, they expressed regrets for their absence. Next, we have DDS, California Department of Developmental Services. DDS, okay. Next, DHCS, California Department of Healthcare Services.
Good morning, Liz Jacobs, we're here, and we have some additional team members as well, so I'll turn it over for them to introduce themselves.
Good morning, this is Dewey here for with DHCS. I think Jerry is also having, she's gonna be here, but she's having issues with the Zoom link.
Thank you, Liz. Thank you, Dewey. And next we have a DOR, California Department of Rehabilitation.
Good morning, Anna Acton here with the Department of Rehabilitation. And I'm not sure who else is on. Regina.
Hi, good morning, everyone. My name is Regina Catamarti with Department of Rehabilitation.
Thank you, Anna. Thank you, Regina. Last but not least, for our ex officio members, we have SILC, Silk State Independent Living Council. Okay, okay. Any members we have missed and want to introduce yourself? Perhaps you came in after your name was called. All right. Turn it back to you, Cindy and Eli. Thank you.
Thanks, Wilson. So next item up is to review the agenda and approve the previous meeting minutes. Do I have a motion? Any changes that anybody saw? Motion? Second?
Second.
Great. All those in favor?
Aye.
Aye. Aye.
Okay, motion carries.
All right. We're on to agenda item number 3, the committee work plan progress reports. This will be for our data and outcomes work group, our training work group, and our sustainability work group to provide updates. So each work group has 5 minutes to present their updates and provide an opportunity for discussion. So why don't we start, since we have Elaine in the room, and Letty, with data and outcomes.
So, I was gonna hand this off to Letty, but I could just say it. We didn't meet, this month or last month. We're waiting for the definitions. And as soon as we get the definitions, that's our next project. So it's going to be a very short 30 seconds, not 5 minutes.
That's okay.
But that's where we are with it. So we're excited to get going on that. Letty, anything else?
Ditto. But if I still have 4 minutes, I can talk about other things. No, yeah, I think we've been looking forward to those definitions and really diving into them. So yeah, I think we're all looking forward to that next phase of this work group. Thank
All right.
you.
Thank you both. Next on the list is our training work group. And we have Carl on the Zoom and Victoria in the room. And Victoria is pointing to Carl. So,
And Carl is pointing to Victoria.
And Carl's pointing to Victoria.
So, I don't know that either of us have much of a update for you this morning. We apologize.
So I don't know that either of us have much of an update for you this morning. We apologize.
Victoria.
Victoria?
I love you, Carl. So hopefully everybody can hear me. So the only update that I will provide for the work group is that we did some work on looking at the training plan, the deliverables for the training work group deliverables. And then we haven't had a meeting, and we're going to, reconvene again like later this month. So no real update other than we have looked at our deliverables for the work group.
And then just a plug that the training for HBO staff are out there and in progress. I'm not sure if the window to sign your staff up has closed. Actually, I think it may be closed, but that project is ongoing.
And then just to plug that the trainings for ADRC staff are out there and in progress. I'm not sure if the window to sign up your staff has closed. Actually, I think it may have closed, but that project is ongoing. Carl, this is Courtney. That window has closed.
Thank you. Back to you, Eli.
Thank you. Back to you, Eli.
Carl, thank you, Victoria. Our last work group, sustainability. We have Larry in the room and Joseph wearing a beard and back from vacation.
So we should throw it to Joe. This is Larry Grable, one of the co-chairs, and I know Joe has been on vacation, so I won't do that to him. Basically, we've met a couple times, but just talking more about the document that has been sent out to all the ADRCs on the funding list. But I think really our talk this afternoon is really where we're headed. Yeah. So there's really no new. Joe, you have anything?
No, nothing to add. Thank you.
Thank you both, and Wilson has his hand up, so Wilson, take it away.
Yes, thank you. Wilson from CDA again. So I just want to kind of add on for our, just to kind of provide some additional insights that for our CDA ADRC Bureau staff, we've been doing a lot of behind the scenes like development work, and we haven't had anything yet these last couple months to share with our work groups for feedback and input and all that. You know, as part of our meeting with the work group chairs later on this afternoon, we'll be kind of talking about, you know, what are our priorities for the next months and for the next year. Hopefully we'll have more updates to share at that point. So, you know, I just want to mention that so that, you know, everyone knows that, you know, we are busy, we are still working and developing things, and that, you know, not that we're just sitting around, you know, twiddling our thumbs or anything.
That our suspicion.
Yeah, I know, I knew it. That's why I had to speak. I knew it.
We'll put that in the official record. So, yes, and as Wilson said, we do have a strategic planning session right after this advisory committee, which is where we're gonna flesh out a lot of our efforts moving forward. So great, we're ahead of schedule on our agenda here. So we will go to our next item.
Okay, next up, we're talking about ADRC funding updates and starting with Amanda.
I'll move on camera here. Oh. Okay, hopefully everyone can hear me. One of the things our team has been busy with is getting ready for the next fiscal year ADRC infrastructure grants. So just a quick note about these grants. They are intended to support emerging ADRCs in their development and then support designated ADRCs in developing, implementing and sustaining partnership and giving consumers access to long-term services and supports. So far CDA is moving forward with the contracts for next year for 25 of our 26 ADRCs. New emerging ADRCs will not be eligible to receive grants this year. With the current budget situation for this state, we're really excited that the contracts are going to be moving forward. So for the next fiscal year, which begins July 1st, there will be $10 million, the $10 million grant really is being awarded to those 25 ADRCs. And the allocation methodology used is the similar one that's been used before. So that really is a base funding for emerging ADRCs at $90,000 and for designated ADRCs at $180,000. And then the funding allocated to local ADRC partnerships beyond that is based on county population of all ages, county square miles, and county geographic isolation. So more on that to come. The other note for our last fiscal year, we are looking at expenditures, and for those ADRC partnerships that are kind of looking to track a little lower in this spending, we're really working to provide technical assistance to and ideas to make sure those funds are expended fully by June 30th when the grant finishes for this year. So I think that's about it for today. Thank you.
Thanks, Amanda.
Amanda, do you have a time frame?
We hope soon, you know, maybe in the next week. I don't know. We were hoping in the month of March. Yeah. Okay, great. Okay. Yeah. I wish I had more.
Any other questions for Amanda? Okay. Thanks. Up next is Janice on the Medicaid Administrative Claiming, also known as MAC, the time study updates.
Thank you, Cindy. Good morning, everyone. So we conducted a pilot MAC time study during the month of February and had participation from 14 ADRCs. For any ADRCs that participated in the February time study, please email me your time study spreadsheets by the end of today if you have not done so already. CDA has also brought on a consultant called the Lewin Group, and we will be leveraging the experience, knowledge, and expertise of the Lewin Group over the next 8 months. In these next few weeks, CDA and Lewin Group will be meeting individually with ADRC partners who participated in the time study to analyze the time study submissions, get feedback on the time study process, and determine the potential amount of reimbursement available. And we will share these findings with stakeholders in the near future. If you have any questions about MAC, please email our ADRC inbox. Thank you.
Great. Thank you, Janice. Any questions?
So I have a question. What is the time frame for when we're actually going to be, I guess, drawing down MAP dollars?
Wilson, are you there? Did you want to respond to that, or do you want me to?
Cindy, Wilson from CDA. So our there are some parts that are controllable on our part, and then there's some parts that aren't controllable. So it's hard to kind of pinpoint exactly when we would be able to start drawing down. So our timeframe working with the consultants will be through the end of October. So we're hoping at that point we would have we're calling it a federal submission packet. So it's basically our proposal that would go to our state Medicaid agency, DHCS, and CMS. We would have all the training materials and the guidance for our local partners, all that completed. We're shooting for at the end of October. The uncontrollable part is, for the review process, obviously, with our state Medicaid agency and with CMS, that may vary. And so right now at this point, I don't have exact date for you, but I hope that kind of gives an idea of the rough time frame that we're looking at in our development.
So potentially 25, 26.
Potentially in 25, 26. Yeah. So different things have to kind of like line up too, but without going into the details. So we hope that the next time we meet again, we'll have some hopefully some more details and dates that we can shoot forward. But those are the timeframes that we're aware of at this time.
Any other questions? Thanks, Janice. Thanks, Wilson. So next up is a report out, and I think Mike's on the phone for the Medicare Improvements for Patients and Providers Act, MIPA.
Hi, yeah, thank you. So for MIPA, we really don't have any current funding updates. Right now, we're working on our semi-annual report to ACL. It's due at the end of March. So that's kind of where we're at right now. Typically, new funding opportunities happen in the summer. So we will obviously make sure everybody is aware of those when those come about. But yeah, just reporting at this point.
Great, thank you. Any questions? Okay. I will turn it back over to you.
All right, so our next item is going to be a presentation from Christy Kalinsky from the Administration on Community Living on opportunities to expand services through aligning health and social care. I think on the agenda, it's Medicare opportunities for addressing health and social needs, but all the same. So Christy, if you are on the Zoom, please join us, and love to hear you.
Hi, Eli. This is Janice. We're looking at the attendee list and panelist list right now. It doesn't look like Christy is on yet. I think we are 5 minutes ahead of time, so she might not be on here yet.
Gotcha. So we have to do some improv. We can move things around. Oh, yeah.
So if Leigh, if you've gotten on, I know that you had to hop off early today and wanted to do an update, so this would be a perfect time for you to do an update if you're on. But maybe not such a good time if you're not on.
So I have a general question. How about that?
Yeah.
For new emerging ADRCs, I know several organizations are working on it without funding. Is there any timeline where you anticipate there will be additional money to put towards emerging ADRCs? just general question.
Yeah, good question, Elaine.
Good question, Elaine. Wilson from CDA. At this time frame, we're not sure at this time because of, as you are aware, with the state budget landscape and such, we're fortunate that we've so far, as part of the governor's proposed budget and discussions, it seems like that 10 million of infrastructure grant has stayed intact. Of course, that can change and such, but from what we've heard, there hasn't been any changes to the infrastructure grants. And what we've, as part of discussions from previous years with our 25 ADRCs, we had talked about maintaining their funding levels.
Right.
And because of that, for our new ADRC partnerships coming on board, there isn't any funding until potentially new funding comes online later on in the future. But this time, we don't know what that will look like.
So even if somebody goes through the process and they can become designated without any funding, would support as an emerging, would they then, would you designate somebody?
Yes, because it is, we do see it as or treat it as a separate process from
Okay.
from the, ADRC development process through, achieving designation status. It's different from the funding part of it, so.
So if they became designated, would that be part of the 10 million? So would it be spread out? Would they still no money?
Still
Even
no-
at,
still-
okay.
Because we're right now tapped out for the cap for the 10 million.
Okay, I have a meeting with another county, and so I know that's gonna come up next week, so I just wanted to have a good answer.
Yeah, and Wilson again, CDA, just want to kind of throw in a plug too that one of our colleagues with our ADRC Bureau, Allison Marks, had put together a great document on different funding sources, and that's why we've worked to kind of compile these different funding sources, because we are aware that these state general fund dollars, they're it's at 10 million. And we don't know about the state budget situation, so we are highly encouraging, you've heard this multiple times, braiding and blending of funding. And so we hope that our ADRC partners will consider those different funding sources to, not have all the eggs in one basket, so to speak, so.
No, that's great, thank you.
And Ramon has his hand up.
Well, if we're sort of on good and welfare, well, I guess we, wait for folks to show up. Sorry, I'm late. I didn't realize daylight savings had started. Anyway, now I know. So how many ADRCs currently are 10 million supposed to take care of?
25.
Okay. I just want to add that I saw that the state of Oregon got a waiver last month for long-term care, federal waiver, and one of the items in the waiver is what they call options counseling for long-term care, which I was on a call yesterday to struck us as, well, isn't that ADRC money? Couldn't, maybe we could get that waiver. I could send you the waiver letter. And it turned out the person who is working on it for CMS is J.C. Cooper, who's out of California.
Also maybe something we add to our discussion this afternoon. Great, thank you, Ramon. Just checking, do we have our guest on from administration community?
Not yet, Eli.
On this kind of topic of funding and sustainability, and I know we've talked about it at the last couple ADRC advisory committees, and Anna presented on it 2 meetings ago, but we as a network have an opportunity to really leverage the Community Living Fund, the Department of Rehabilitation. And I know that many of us are leaning into that, but my understanding is, we're still behind on our annual targets for enrolling folks in the Community Living Fund for Transition and Diversion. And that Community Living Fund both has a resource to support consumers in their transition and diversion up to $5,000, I believe, but also there is a services and administrative reimbursement to the organizations administering the CLF which in most cases, I believe, are independent living centers and ADRCs. And that is, you know, I believe we're halfway through the 3-year pilot. So really an opportunity to make up some ground, and in addition to the other funding sources we're exploring, something we can take advantage of literally right now. And kind of maximize that effort so we ensure that the community living fund dollars do not go away in any sort of you know, budget cut or shortage. And also that we can demonstrate its you know, efficacy for future, you know, basically to establish it as a future funding source that continues beyond the pilot, beyond the 3-year timeframe.
I will piggyback on that. When we had that similar type of funding in San Francisco and started it a long time ago, it was hard to get people out of the scarcity mind frame.
Yeah.
And so I think the more we can think about it and put it front and center, the better. Once people get used to it, then it goes like crazy, but it is hard to get out of that scarcity mindset.
It took us for Marin's ADRC and Marin CIL, the administrator of the CLF. It took us a couple months to kind of refine, to your point, Cindy, the process for, you know, gathering, you know, all of the, you know, necessary information from the consumer, you know, kind of streamlining operationally how we do it on our end, between services and administration and kind of payment and billing. And then also for DOR.
Hi there, can people hear me?
Yes.
Yes, do we have Christy on the line, or who's?
Yes, that's Christy.
Great.
Yeah.
So, yeah, just my last point on this was, as we've refined our internal process, and then with their process, we've really developed a efficient way to, you know, kind of speed it up. So Christy, oh,
Joe, do you have
sorry.
a quick question?
Yeah, thanks. I just want to make a quick comment. You know, I fully support this concept of braided funding, and it's in the sustainability plan. I just want to bring the point, and again, knowing the issue right now with the state and the state budget, but you know, moving forward, I don't know how we can support, you know, CDA 2030, the no wrong door approach that the master plan and agency is approaching, without at least having a really good conversation about funding through the state for this, because I think all AAAs and independent living centers can be ADRCs to some extent, but the administrative requirements on this, there's got to be some funding for them. And my concern is when we meet, we know the situation with the state and the budget, but it kind of feels like we dodged the question. I think we need to take it head on. We need to talk about funding from the state to support ADRCs. We need everyone to be an ADRC. And I think it really supports CDA's mission of what they're looking for as a no wrong door system. So I would just like to say, can we talk about this? As hard as it may be, we need to go to the state and look for money to have more ADRCs come on, because you're not going to be able to be an ADRC simply with using your existing funding and braided funding. It's part of the it's part of the formula. But I'm just concerned that we've kind of got to this point where it's 10 million, there's no more, and there's nothing we can do. So I just want to bring it up, and for future discussions, we need to take it on. Thank you.
Thank you. Yeah, noted. And I know our two associations, CFLC and C4A, are also working on a bill, and hopefully we'll get an update on that during the report outs. Thank you, Joe. So we are ready for our presenter, our guest, Christy Kalinsky from the Administration on Community Living. Christy, looking forward to hearing your presentation on opportunities to expand services through aligning health and social care. You're welcome to get started.
Great, thank you so much, and apologies if I held you up at all. I had some Zoom difficulties, but I'm glad that I was able to join. Happy Friday to everyone. Thank you so much for the invitation to join your meeting today, and to highlight some of ACL's work to better align health and social care to address health-related social needs for older adults and people with disabilities. So I'm Christy Kalinsky. I'm a team lead in ACL's Office of Network Advancement in our Center for Innovation and Partnership at ACL. Next slide, please. So I wanted to spend just a minute highlighting social determinants of health, or SDOH, and health-related social needs, or HRSNs. I know I often hear these words used interchangeably, so I think it's helpful to start with some grounding in SDOH and HRSNs. SDOH are the conditions in which people are born, live, work, play, worship, etc. They're more upstream factors, so things like lack of affordable housing in a community, food deserts, etc. The health-related social needs are really at an individual level that impact health and well-being. So that's somebody's housing instability, if they have food insecurity, and health-related social needs sometimes can be the result of social determinants of health, but not always. Next slide, please. So within the Department of Health and Human Services, or HHS, and really government-wide, advancing health equity by addressing both SDOH and HRSNs is a key priority. So I wanted to highlight two resources that came out in November of 2023. There were actually a couple of resources that came out at the same time, complementing one another, but two I'll highlight. The first is a US playbook to address social determinants of health. It's organized by 3 pillars, which you can see here on the screen. And it really represents efforts across the federal government. So a whole of government approach, not just HHS, although HHS programs by nature, because it's SDOH specific, are certainly well represented. So those 3 pillars are centered on data gathering and sharing, flexible funding to address social needs, and then the third is supporting community backbone organizations. So this third pillar is really most relevant to our discussion today, and ACL's work in supporting community care hubs, which I'll go into some more detail on in a minute. Some of you may be familiar with that concept as a type of backbone organization, is highlighted in this pillar. And I will say that the resources that I'm sharing, once I'm finished speaking, I can drop links to the chat in that, unless Wilson or someone else has already shared this info, but they're really great to check out. Next slide, please. So another resource that was released in November is an HHS specific document, and that's a call to action on addressing health-related social needs in communities. The call to action really complements Pillar 3 of that White House playbook, and it identifies concrete, specific actions that various stakeholders, so it talks about community-based organizations, calls out health plans, healthcare providers, public health organizations, IT partners, etc., and really what the actions each of those individual stakeholders should take to support community infrastructure to address health-related social needs. So its purpose really is to catalyze those cross-sector partnerships to enhance coordination, to leverage resources, etc., rather than working in silos and duplicating investments, duplicating infrastructure. Next slide. So I wanted to highlight some of the example actions. You can see that for community-based organizations, either serving as the lead organization for a network of CBOs, that community care hub, or participating in the hub network is called out. Health plans and other payers are explicitly called on to pay for allowable services and partner with community-based organizations, partner with hubs. And I think it's really important to point out here that this isn't an ACL specific document where we're saying, you know, on behalf of community-based organizations, here's what we think all of these other sectors should do to support the community infrastructure. This resource has buy-in from across the department, including CMS, including CDC. It went through clearance through all of those agencies. So it certainly reflects our ACL priorities, but I think it reflects the priorities of the department as well. So that's really important to note. Next slide, please. So both of the resources that I just described are reflective of the fact that opportunities to align health and social care are more present now than ever before. I want to point to some of the examples. So the White House Playbook, the HHS Call to Action, I know I just covered. There's Medicaid 1115 waivers that are supporting these investments to address social needs across the country. Certainly CalAIM, you know, really was a front runner in these Medicaid 1115 waivers. CMS has also released guidance on in lieu of services for state Medicaid agencies to address social needs through Medicaid managed care. And then we're also seeing a number of CMS policies as well as, you know, payment and then quality measures that are really incentivizing or requiring screening measures for social determinants of health for hospitals, for physicians and special needs plans. Medicare ACOs have the opportunity to draw down on some advanced incentive payments to address health-related social needs. And then the 2024 Medicare Physician Fee Schedule final rule, which I'm going to touch on in just a minute, was really transformative in this area as well. So this is all really fantastic that we're seeing from the healthcare side, some of the policy and the payment mechanisms to address social needs. One of the challenges that we're keenly aware of at ACL and really across the government is that we need to make sure that there's capacity in communities to effectively partner with healthcare and address these social needs. We're seeing an increase in referral volume across the network. We want to make sure that we're not building what's effectively a bridge to nowhere, where people are being screened for social needs, they're being referred to community-based organizations, and then there aren't services in the community available to support them. That's not a win for anyone. It's not a win for the healthcare providers. It's not a win for the community-based organizations who want to serve them but are under-resourced. And it's certainly not a win for the people who need those services. We know that Older Americans Act is a really important starting point. There's other federal formula funding, state funding, et cetera, that I think really serves as a critical foundation for these services. But we know that we need to be able to braid in other sources of funding, both public and private, to really deliver comprehensive services to meet that need. Next slide, please. So as I mentioned earlier, I wanted to highlight that the 2024 physician fee schedule has been a really important healthcare policy driver. This is the first time that Medicare has included codes that specifically call out services that address health-related social needs. So it goes beyond those clinically oriented services and calls out contracting with community-based organizations to deliver two of those services, community health integration and principal illness navigation services. The community health integration services are really intended to address unmet social needs that are affecting diagnosis and treatment of a patient's medical problems. So I would call that out. You know, those unmet social needs have to have an impact on the individual's health and health problems for it to really meet those criteria. The principal illness navigation services are a similar set of services, but that's really to help people with Medicare who are diagnosed with certain high-risk conditions to really help them effectively navigate. I'll put in a plug that the Partnership to Align Social Care with support from ACL just developed a primer resource on both the community health integration and the principal illness navigation codes. There's going to be a more thorough implementation guide that's coming in just a few months. And like I said, as with some of the other resources, I will drop that link into the chat in just a few minutes. That one is hot off the press. I think it was posted on Wednesday, so it's pretty new. Next slide. So I want to take a minute just to dive a little bit deeper into the Community Health Integration Codes, or CHI. There's 2 codes. The first is for 60 minutes each calendar month, and then the other is for any 30-minute increments that kind of follow that initial 60-minute session. So these are billable activities, as you can see, that are really well aligned with the work that ADRCs and other aging and disability organizations are doing each and every day. We see person-centered assessment called out, care coordination called out, healthcare navigation, facilitating behavior change. If you actually go into the physician fee schedule, each of these bullets that I have listed on the screen has like sub-bullets that's further detailing and calling out information. Care transitions is included in there. So as you can see, really reflective of services that are core to the aging and disability networks. Next slide. And it's also really important to note that ACL's network, ADRCs, AAAs, CILs, are explicitly called out as organizations that Medicare providers can contract with for what they term auxiliary personnel to provide both the CHI and the PIN services. This language is directly from the physician fee schedule. I copied and pasted it. The bolding is mine, just to show where CBOs and ACL's networks are referenced, but honestly, I don't know that I could have written it better myself. So it's really great to see that our AAAs, our CILs, ADRCs, et cetera, as well as other organizations that are part of ACL's network are being explicitly called out in the physician fee schedule. So I know I've covered what I think is a really exciting, yet also I acknowledge a very complex topic in, I don't know, a minute and a half, 2 minutes. So I do want to point out that there was a great webinar that was hosted last week or the week prior by the Aging and Disability Business Institute at US Aging that goes into much more detail. And as I noted, we'll have a number of resources coming out that are supporting the implementation of these billing codes. So if you're interested in learning more, I highly suggest you check out those resources. Next slide. Okay. So we know that contracting between community-based organizations and healthcare organizations, it's happening across the country. It has been for a number of years, and it's growing. And this contracting is really important to making sure that that capacity exists in communities to address the unmet needs. As I said before, our Older Americans Act dollars aren't enough. We really need to be able to bring in sources of public and private dollars, braid those resources, and really holistically address an individual's social needs. This information is from an RFI that the Aging and Disability Business Institute does with Scripps Gerontology Center. It's from 2021. I know that they have just released the data from their 2023 RFI. I got a sneak peek at it. We're continuing to see the contracting growing, as well as contracting as part of a network. So it was 20%, I believe, in 2017, and then increased to 40%. So not only are organizations contracting independently, but they're also organizing, whether formally or less formally, to contract as part of a network with healthcare. Next slide. Okay, so these contracts that are the contracting that's happening as part of a network versus an individual organization. The networks are led by what's known as a community care hub. So across the network, we've been using this nomenclature for a few years now. Prior to that, the organization was known as a network lead entity, but the community care hub is really that community-focused organization that's organizing, they're supporting the network of CBOs, and those CBOs are providing services that address health-related social needs. And really, the locus of the community care hub is to centralize those administrative functions and the operational infrastructure that's needed for healthcare contracting. We know that healthcare contracting is is not easy. It can be really resource intensive, and to have individual organizations across a geography that are all investing in that capacity and duplicating that resource investment isn't necessarily efficient, and it's really not necessary. So, having all of that centralized within a community care hub, and then they have that operational infrastructure to handle the contracting, the payment operations, referral management, service delivery, if there's any fidelity of interventions, compliance with the contracts, and then of course, any of like the technology, the data collection, etc. And I think it's also really important to point out that the hub is an organization that's trusted in the community. They understand the capacity of the community-based organizations across their community, but they also understand kind of the healthcare culture, and they have trust with healthcare organizations as well, and really foster that cross-sector collaboration. Next slide, please. So I want to highlight no wrong door ADRC system alignment with community care hubs. These are a few of the items on the screen here, but I would say an underlying goal of these hubs is to foster a multi-payer approach to provide services to anyone in need, regardless of age, income, etc. I know that's key to No Wrong Door Aging and Disability Resource Centers as well. I don't think I can state enough that our grant funding alone is not enough to meet increasing need, and the hubs really help to expand the reach of local community-based organizations so that they can serve more people in need of programming and services. The role of a state's No Wrong Door system in coordinating information and referral, interoperability, those sorts of things is also really important with respect to community care hub implementation. Without this coordination that often happens at a state level through a No Wrong Door system, we've seen a lot of burden on individual community-based organizations, on hubs, to navigate referrals across multiple vendors. Sometimes it's the same vendors, but it's a different instance of that vendor within a different organization. It just gets really messy. So I think there can be a role there for a No Wrong Door system to help to coordinate some of those information technology pieces. And then finally, and I really can't emphasize this enough, the access functions and the person-centered approach that's core to No Wrong Door is really beneficial to community care hubs as well. I think there's a lot of opportunity for cross-training, training from the No Wrong Door system or ADRCs into the community care hubs where they're not one and the same, to really make sure that a state's access system is being fully leveraged and we're not duplicating anything, and making sure that hubs and their network partners are trained in person-centered practices. That person-centered piece is so core, and just as it's core to an aging and disability resource center and the No Wrong Door model, it should also be core to community care hubs. Next slide. So I want to highlight that ACL and our partners are providing an array of technical assistance opportunities to really support a variety of organizations. So whether that's an organization like a state level agency, a community-based organization, a community care hub, a healthcare organization, at various levels of maturity as well with their health and social care alignment activities. I think we recognize there's a lot of opportunity in this space. There are also a lot of challenges in this space. And we really want to provide as much TA kind of to the right individuals or the right organizations at the right level as we can. I would point out, I'm going to go into just a few of these in a touch more detail. The Community Care Hub 101 learning series is a great starting point if you're interested in learning more about hubs. You can also share it with partners. That could even be like healthcare partners or partners across your network, so that they have a better sense of what it means to be a community care hub, to be engaged in a community care hub, what the functions are, etc. That's a 4-part learning series, and it's all available online. And I'm going to touch on a few of these as we go through. So let's go to the next slide. So our 2023-2024 National Learning Community, this is specifically for community care hubs that are either currently operational or those that are interested in becoming a community care hub and have some level of healthcare contracting capacity at least. So for those organizations that are just kind of thinking about becoming a community care hub but don't have that contracting capacity or really just want to learn more about it, the 101 is perfect for them. The National Learning Community is geared toward those that, are various levels of maturity of hub operations, or as an independent organization already have some contracting capacity and now are considering taking that next step into a hub model. So built on the success of our first cohort in 2022-2023, so our current one is year 2. We have 32 organizations participating across 23 states, including California. We're using the Project Echo All Teach, All Learn model, which is really nice. So it's not just an individual who's sharing information in like a webinar format, kind of similar to how I am now, but really participants have the opportunity to learn from subject matter experts, also learn from their peers. There's case study discussions. It's a really nice model. So there's monthly echo sessions. The first 3 months were offered in collaboration with the Partnership to Align Social Care and their Health Equity Learning Collaborative. And we really focused on the new Medicare billing codes for community health integration and principal illness navigation. And now coming up in April, we're moving into a 3-part series on healthcare contracting. And then we'll wrap up this summer with a 2-part series on value propositions. Another really nice piece of the National Learning Community is that participants have access to a bank of hours that they can draw down for individual consulting with subject matter experts. And people have found this really valuable as well. So they're getting that subject matter expert instruction, they're getting the peer group piece, and then they get one-on-one with consultants as well. Next slide. So I want to quickly highlight our online map of NLC participants. I would caveat that this is not an exhaustive list of hubs across the country, just those who have participated in our learning community over the past 2 years. You can see here, California is participating, and we have 3 participants. I believe in our current cohort, we have the Area 4 AAA, the Marin Center for Independent Living, and then Partners in Care Foundation as well. But a lot of representation across the country. Next slide. As I mentioned earlier, we know that the infrastructure funding, both to kind of get a hub off the ground, as well as to enhance or expand a hub, is really expensive, and it can be challenging to raise the capital that's needed to really make those investments. So we have a funding opportunity for community care hubs. This is offered by the ACL funded Center of Excellence to Align Social Care. So this is a grant that ACL awarded to US Aging and their Aging and Disability Business Institute, and 80% of the total grant award that went to US Aging is being re-granted back out to the community to provide these infrastructure grants. The other 20% is for technical assistance and other activities to run the Center of Excellence, but really the bulk of it is for this infrastructure funding. So we're anticipating 20 awards, about $468,000 over 2 years. And applications are due on April 5th. So I wanted to make sure that everyone is aware of this funding opportunity. There is still time to apply. Next slide. All right, and finally, I want to wrap up by highlighting 2 initiatives that are part of the National Learning System that I mentioned earlier that I think certainly have relevance to aging and disability resource centers. Full caveat, these are led by my ACL colleagues, not myself, but I will do my best to do them justice, and certainly encourage you, if you have any additional questions about them, to reach out to me, and I can put you in touch with my colleagues who are leading them. So the first is a Housing and Services Partnership Accelerator. There are 9 states that are participating in this accelerator, including California. I believe it is the state Medicaid agency that's participating. And the goal of the accelerator is really to support states and communities to accelerate the development and the implementation of innovative state strategies to provide housing-related activities, housing-related supports to people with disabilities and older adults. And these are individuals who are either experiencing homelessness or at risk of experiencing homelessness. And really the rationale is that we know that when you coordinate housing assistance and wraparound services, it helps people transition out of homelessness. It helps them exit or avoid institutional settings, and ultimately, it enables their ability to live in the community. Next slide. So the 9 states are working on a variety of housing-related activities and supports. You'll see transitions and navigation services, home remediations, behavioral health, home mods, tenancy sustaining services, et cetera. So there's really quite the diverse menu of services that or activities and supports that these states are working on through the accelerator. Next slide. So this accelerator will operate for 12 months. It started in January. We've had a lot of learning opportunities that kicked off in January. I was a little concerned that we flooded our network with opportunities, but we've had a really good response to all of them, and it'll wrap up in 2024, or December of this year. I want to point out that the cross-sector teams in particular, disability and aging, are expected to be part of each state's team. The accelerator, it's just getting started, but we've been thinking through at ACL how to make sure that aging and disability organizations at the local level are best engaged in this process as well. I certainly see a role for ADRCs, for AAAs, for SILs in navigation, transition services, home modifications, those sorts of things that were described on the last slide. So while we've got primarily a focus on the state agencies now, there is that expectation, like I said, that disability and aging are part of the team. And we're really thinking through strategically kind of timing and opportunity to make sure that local organizations are engaged as well. Next slide. So I also want to highlight our Care Transitions Echo series. This launched in January too, and the focus here is on healthcare CBO partnerships to improve hospital to home transitions in particular. So we've got hospitals, accountable care organizations that are partnering with community-based organizations in their community and really strengthening that collaboration between the community and the healthcare sector is a central tenet of this Echo series. Next slide. So I wanted to share a quick snapshot of the topics that are covered in this Echo series. It's really taking participants through the entire transitions process from start to finish. So going over the impact of social needs on transition, starting with that screening for social needs, moving on to the communication pathways, how to get community-based organizations engaged in that transition, short and long-term services, billing pieces, et cetera. So really a very nice comprehensive curriculum there. Next slide. And this map is from the kickoff call. I borrowed a slide from that, but I did recently receive some information that showed that there are, I believe, 16 organizations, there were at least 15 that have participated in this Echo series from California. So there are a number across both community-based organizations and healthcare. So I'm happy to share more information with anyone who's interested if you'd like to make those connections. And I think we have Kristen Vangeloff from the Lewin Group on this call, who is supporting this Care Transitions Echo session. So we can make sure that you get in touch with the right people if your organization would like to get engaged. All right, so finally, wrapping up, we really see that the population demographics in our country with older adults, people with disabilities, and the policy drivers that I covered earlier are going to continue to increase demand on ADRCs, on AAAs, SILs, and other CBOs to address social needs. We also know that this work closely aligns with the core competencies of aging and disability networks. We've been addressing health-related social needs, even though we haven't been calling it that, but we've been doing this work for decades. And we also know that if our network can't effectively respond, if we're not resourced enough and organized to respond, we've seen that others will. And they'll likely be for-profit, not that that's necessarily a bad thing, but also likely to be less connected to community, which would not be a strength. Strengthening this community capacity to provide services is vital. We want to make sure that we avoid that bridge to nowhere. That's what our center and our office at ACL is hyper focused on, is that community capacity. And we also know that there's challenges and opportunities to expand hubs. We want to make sure that there's fair and sustainable partnerships between CBOs and healthcare. And that's really one of the central tenets of community care hubs, is that we do have those fair and sustainable partnerships. It allows for smaller community-based organizations that perhaps wouldn't have that capacity or those resources to contract with healthcare, the investments in IT, contract review, et cetera, to be part of that network and gain benefit from any healthcare contracting that's coming through the hub. We also see incredible opportunities to build on hospital partnerships, to enable safe transitions, to collaborate with health plans, to collaborate with housing agencies, and really make sure that people have housing, nutrition, other supports to enable community living, because this really is all about serving people holistically, meeting their needs, and ensuring that they are able to reside in their community of choice. So with that, I am going to take a breath and invite any questions that you might have.
Fantastic. Thank you so much. That was a lot of exciting and important information. We have a hand up in the room from Ramon. So Ramon, go ahead.
Thank you. It's a very interesting report. It's a little bit like a fireman experience. So much going on. So you mentioned early on that you don't want to see folks getting referred to non-existent services. Do you have a way to measure the extent to which that's going on, and where and which services? And that'd be a very important diagnostic step if you have that available.
It would. You're absolutely right. So currently, what we're aware of is more anecdotal. So what we're hearing from area agencies on aging and different meetings, or kind of hearing about any wait lists that are getting longer, or there wasn't a wait list before, but there is now. But I absolutely agree that having some sort of way to really qualitatively measure that is very important, because as valuable as it is to have, and I mean, I'm a social worker by training, so, addressing health-related social needs, this is all very logical and rational. In my mind, we know that the environments that people live in have an impact on their health and well-being. So it's great that the healthcare sector is really tuned into this and that they're really incentivized. But now that we're seeing more opportunities for payment, but we really need to make sure that we're kind of keeping that pulse on, okay, what's happening on the healthcare side. There's, I think, great metrics and great tracking there, less so on the community side. So I agree that that is an area that we need to be tuned into.
Great. And we will be able to get, you mentioned a whole lot of webinars and so forth. That information is going to be made available. Is it already posted, or you can at least send it to us?
It's all posted. Wilson, do you have a preference? I mean, I can send you any resources that I highlighted, and then you can distribute it to the group.
That'd be perfect. Thank you.
Other questions from committee members, either in the room or on Zoom? I will add Eli with Marin Center for Independent Living. We are really excited to be a part of the National Learning Collaborative, and it very much ties into our local work around CalAIM, our coalition with our local healthcare partners, and the health equity work. We're kind of building as a system. And just, I know, speaking for our organization and our ADRC and our team, that it is a big lift on top of everything else we're doing, but having, the resourcing and support, whether it's CalAIM, working in the ACL collaborative, learning and hearing from other communities and other peers that are engaged in this work, it really is valuable as we're kind of building these new planes and getting them off the ground. And I did have a question about the CCH Center of Excellence funding. And I'm sorry, I probably should have known about this grant, but I didn't. In terms of eligibility, is it open to organizations, ADRCs, states? Could you speak criteria for who is eligible for these awards?
Absolutely. And my apologies if you can hear a dog carrying on in the background. It's one of those days where my husband is out at a meeting, I'm here, I drew the curtains, I put a note on the door that said, don't ring doorbell, and something still has my dog triggered. So hopefully it's less distracting for you than it is for me. But to respond to your question, so any nonprofit organization can apply for this funding opportunity. So, Centers for Independent Living, area agencies on aging, even technically a nonprofit healthcare system or university could apply. Now, of course, there's eligibility, and then there's the actual criteria for a successful grant. But in terms of eligibility to apply, it is a full and open competition for any nonprofit organization.
Awesome, thank you. I see a few hands up on Zoom. So I see Anna's hand and Carl, so we'll go Anna first.
All right, thank you so much. Yeah, thank you so much, Christy, for the presentation. I just wanted to put a word in for the Housing and Services Partnership Accelerator that you mentioned. Thank you so much for covering that. I think we're really excited here in California about that opportunity. To really support our development and expansion of innovative housing related services for the Medicaid population through CalAIM initiative here in California. So we had our first technical assistance with you really yesterday, I guess it was. And we're really excited to bring in the independent living centers, the area agencies on aging, the ADRCs. And we are planning to work with our foundations, the California Foundation for Independent Living Center, as well as the C4A, and work directly with some of these local organizations who are doing this great work around housing, building their capacity to engage with managed care, and to provide these services collaboratively. In California, we have 28 centers for independent living. We're California, so we call them independent living centers. But we're seeing 10 or so of them already contracting with managed care through CalAIM. They're doing the housing supportive services, they're doing transition services, they're doing enhanced care management. So we're seeing some really exciting leadership here within the independent living centers on engaging with managed care that I think that we can really build off of, support, and enhance. So I just wanted to thank you for mentioning that. And we're watching, we're a partner, and we're going to be engaging with our local CBOs. So
I'm so glad you're on. And you were able to speak to that from a California lens much better than I could have. So it's great to know that the ADRCs, the CILs, the AAAs are going to be engaged throughout that process. Thank you so much for sharing that.
Thank you.
Great, and we'll go to Carl.
Yeah, I echo all of what Anna just said. Thank you, Christy, for the presentation.
echo all of what Anna just said, and I thank you, Christy, for the presentation.
I guess I have more of a general comment about the movement we are seeing where ADRCs and ILCs and other CBOs are partnering more with managed care.
I guess I have more of a general comment about the movement we're seeing where ADRCs and ILCs and other CBOs are partnering more with managed care.
Number one, obviously it is very exciting for from multiple different angles.
Obviously, it's very exciting from multiple different angles.
But I guess my comment is more about the cultural competency that we can bring to the medical field as signals for independent living.
But I guess my comment is more about the cultural competency that we can bring to the medical field as centers for independent living.
And I know that this is applied accordingly within the medical field to be more confident and aware specifically of people with significant disabilities.
And I know this is a priority within the medical field to be more confident and aware specifically of people with significant disabilities.
But finally, I just want to say a word of caution to my colleagues in the ILC world.
But finally, I just want to say a word of caution to my colleagues in the ILC world.
Yes. As we are embarking down this road, let us be sure to maintain our own values as we go.
So as we're embarking down this road, let us be sure to maintain our own values as we go.
That's a terrific comment, and I wholeheartedly agree. And I think, something that we're really mindful of and really cautious of with the community care hub model, with healthcare CBO contracting, is really maintaining that community-centered lens, and not taking something that's community-centered, person-centered, and medicalizing it. And I think that's where there's real opportunity for aging and disability organizations to have a seat at the table, to make sure that those values are translated into some of those contracting arrangements, into the services that are being delivered, and really having a seat at that table is very important. And I agree wholeheartedly, Carl, with what you said. I would point out, if you haven't seen it already, there was a webinar last week, I believe, or the week prior, and this is another one that I can send the link, Wilson, specifically for Centers for Independent Living or ILCs in California on the community care hub model. So that was hosted, ACL presented, Richard Petty from ILRU. We had somebody from the Aging and Disability Business Institute, and then somebody with the Western New York Center for Independent Living, who's part of a community care hub. And she was just fantastic in terms of identifying what the opportunities are for Centers for Independent Living, how it's really raised the profile of her center to be part of this network. They're getting a clientele that perhaps they weren't before, who are aware of their services. So I highly recommend that webinar, because it's not just ACL or it's not just ILRU kind of speaking to the virtues of a model or of the healthcare CBO contracting, but I think hearing from independent living was it was really impactful for me.
If I may just make one more comment, and I know your Facebook not stable.
If I may make just one more comment, and I know you're federal, not state, but
we are one of the ILCs here in California participating in CalAIM, and I was on a call just yesterday with a health plan where they were talking about these incentive dollars.
But we're one of the ILCs here in California participating in CalAIM, and I was on a call just yesterday with our health plan where they were talking about these incentive dollars.
And one of the incentives was taking blood pressure every quarter.
And one of the incentives was taking blood pressure every quarter.
My audio cut out. Sorry, but I think you got it. So just keep going. So, of course, as an ILC, that is not really something we do, or and it's not really our role. So thinking more about stuff like that.
Uh-oh, my audio cut out, sorry, but I think you got it, so I'll just keep going. So, of course, as an ILC, that's not something we really do, and that's not really our role. So thinking more about stuff like that.
Yeah, that's a great comment. And I think too that that's where having a network of providers that offer a variety of services to a variety of populations. So if as an ILC, that's not something that you're accustomed to doing, but there's another community-based organization in the network that does do that sort of thing. So I'm sure the MCO is being tracked on. It's a quality measure, it's a HEDIS measure or something like that. And as a community-based organization, you have access to people in their homes. So you're trusted. The MCOs don't necessarily have that same access that you do, and that's an asset for our CBOs. So I appreciate those comments.
Great comments, Carl. We also have a comment in the chat, which Cindy's gonna read.
So, yeah, this came from Jewel, and the question is, for the Health and Social Services Medicare billing code, is the vision that the CBO contracts with the plan at large and then becomes a provider that physician provider refers to?
Yeah, so that's a great question. So with the Medicare billing codes, the community-based organization, the individuals employed by the community-based organization are considered auxiliary personnel. So only the Medicare Part B provider can bill Medicare for those services, but they can contract to a community-based organization that has a community health worker or a peer support specialist, somebody like that, staff at a community-based organization. And then they work out the contractual arrangement with respect to the amount of dollars that are kind of passed down through that provider to the community-based organization. So the Part B provider is still the one that's getting the Medicare reimbursement, but they're like subcontracting that down to the community-based organization because they're able to do that through the auxiliary personnel language in the physician fee schedule. And auxiliary personnel is essentially, they can be personnel at another organization and they don't require direct supervision from the Part B provider, the same way that somebody, within the clinical setting would, they can be auxiliary to that provider.
Great.
And that's explained in the primer document that I put a plug in for earlier. So and likely explained much more succinctly and clearly than I did. So we'll send that out.
So I've allowed Jewel to unmute. It looks like she was trying to say something.
No, just thank you for that answer. Thank you.
Yep, you're welcome.
So just, this is Eli again. One other follow-up on this Center of Excellence Care Hub funding. So in California, and obviously, I'm sure you know this, but many of us are in the early stages of kind of integrating CalAIM, building out our early models for what this Care Hub might look like. Is this funding, targeting more mature care hubs, or would this be something like a new CalAIM provider would be, eligible for in terms of kind of ramping up their work?
Yeah, thanks for asking that. So both. It can be an organization that, we're looking at a spectrum of maturity, is more mature and perhaps is, pretty well established, and they would use the infrastructure resources to really expand or enhance that infrastructure. And then it could be an organization that would really use those resources to build and develop that infrastructure and can be much earlier along. So it's really not explicitly targeting either, nascent or emerging hubs or more mature hubs. It's really any and all.
Awesome. And then last question on this. Does it provide funding for kind of, I would say more like infrastructure development, or is it more technical assistance driven?
No, it's really infrastructure development.
Awesome.
So whatever organizations need with respect, could be that they want to invest in an IT system, or, things like that. So it really is the infrastructure piece. You could be bringing in consultants to help with technical assistance or something like that, but the funding really is for what the hub needs to develop or grow their infrastructure.
Thank you, Christy. Any other questions for Christy? Okay, and you provided your email if there's anything that comes up after the call for our committee. So thank you so much, and yeah, I just really appreciate you leading this work at ACL. It's very exciting.
Thank you all. Don't hesitate to reach out if any questions come up after the fact. And like I said, I'll be sure to share the resources that I highlighted during the presentation. So thank you again for the invitation to share that information with you today. I hope you have a great day.
Okay.
Thanks. So I know up on the agenda next is public comment, but Lay wanted to do an update and had to leave early. So I said that we could do it before we break for lunch. And I think you are on now. Is that true? Okay. Okay, then we're gonna move to public comment. I'll open the line, so to speak.
Hi there, this is Lay.
You are here.
Hi, yes, I'm sorry, I'm just having trouble with Zoom. Thank you so much for this time. This is Lay Arquisola. I'm the Aging Inclusion Specialist for Department of Developmental Services. March is Developmental Disabilities Awareness Month. In declaring this month as Developmental Disability Awareness, Governor Newsom highlighted the work underway to develop a new master plan for developmental disabilities, which seek to strengthen accessibility, quality, and equity for all consumers and their families. So Department of Developmental Services with the Health and Human Services Agency, we're moving forward with the master plan for developmental services with the formation of a stakeholder committee. So the stakeholder committee, it consists of a diverse group of individuals with varying backgrounds and experiences, will help build the master plan. The members of the committee were appointed by Dr. Mark Galley, our Health and Human Services Agency Secretary, for a one-year term with the intent they collectively deliver a master plan by this time next year, March 2025. There's a link on the DDS website and the Health and Human Services Agency website for updates on the master plan for developmental services if you are interested in staying abreast with the master plan. So with that, I'll pass it back to Eli or Cindy. Thank you so much.
Thanks for that. Okay, now I will open it for public comments. Any public comments? Okay, I see no hands. So we are at lunch break and we are pretty much right on time. So it is, according to my computer, 11:33. Come back at 12:33. Okay. Have a good lunch.
Okay, welcome back from lunch. Hope you all on Zoom had as good a time as we did. We went out to sushi, it was delicious. CDA's lucky to have a great restaurant. So for our next item, we're gonna be spotlighting a local ADRC. And that is going to be our Sonoma County ADRC. So I will be handing it over to Allison, who will introduce our speaker.
Hello, everyone. I'd like to present Jordan Rico. A little bit about Jordan. He currently serves as Program Director of Disability Services and Legal Center. He also serves as the Project Coordinator for the Sonoma County ADRC and is a co-chair of Sonoma County's Access and Functional Needs Committee. Jordan has a strong passion for working with people in need. His previous experience includes efforts as a direct support professional, a caseworker, applied behavioral analysis technician, and RCFE administrator. And without further ado, I'd like to present Jordan Rico.
Thank you, Allison. Good afternoon, everyone. Don't have anything fancy PowerPoints to share, but I am happy to share with you today a heartwarming success story that embodies the essence of empowerment and collaboration within our community. Please note that names in this case have been changed for confidentiality. This narrative surrounds Peter, whose journey illustrates the transformative impact of the Community Living Fund and the unwavering dedication of service providers. Peter was staying at a licensed skilled nursing facility, faced with significant challenges due to his complex medical needs, and his declining health had severely limited his mobility, rendering him unable to safely transfer to and from vehicles. This obstacle not only hindered his ability to return home, but also posed difficulties in accessing essential medical appointments or other future crucial engagements. Despite residing in a rural area where resources were not readily available, Peter and his wife yearned for him to be closer to family and regain his independence. A dedicated team of service providers stepped in to offer support and solutions. Through the collaborative efforts of various stakeholders, including DSLC, a core partner of the Sonoma County ADRC, a pathway towards independence emerged. Leveraging the resources provided by the Community Living Fund, DSLC facilitated the acquisition of vital equipment. In this case, a lift and sling compatible with the family vehicle and capable of accommodating Peter's needs. This equipment proved to be a game changer for Peter, enabling him to safely transfer to and from the vehicle and reclaim his autonomy. His transition home became not just a possibility, but a reality filled with newfound hope and freedom. Peter's story serves as an example of the profound impact that collaborative initiatives like the Community Living Fund can have on individuals and families striving to regain independence. It underscores the vital role of ADRCs in fostering partnerships and facilitating access to essential resources. Through continued collaboration and advocacy, we can create a more inclusive and supportive environment where every person has the opportunity to thrive. Thank you, everyone, for allowing me to share this inspiring narrative today. I'm confident that Peter's story will resonate here as we all work together to build a more equitable and compassionate society.
Thank you so much, Jordan. And again, thank you for embodying what ADRCs are all about, and also blending and braiding your funding sources with Community Living Fund.
Outstanding. And I love that the Sonoma ADRC leveraged the Community Living Fund and, connected this individual with assistive technology for his vehicle. Just great example of leveraging a resource as well. Okay, thank you so much, DSLC and Sonoma's ADRC.
Thank you.
Thank you. And yeah, we were just talking about leveraging that funding this morning, so that was a great highlight. Thank you. So up next, Mark is here in person, and so we have an update from California Department of Aging.
Great, thanks so much, Cindy, and good to see everybody. Glad to be here. So for California Department of Aging, I only have a couple of updates, but they're very critical updates that move some of our 2 key initiatives forward this year. The first one is CA 2030, which you've all heard about. I'll just kind of recap what the goals of CA 2030 are, and then talk about where we are in the process currently with implementing different components of CA 2030. So again, CA 2030 was originally envisioned under the Master Plan for Aging to really strengthen the aging network. As we know, AAAs, the backbone of our aging network, were established in the late 70s, early 80s. And since that time, there really hasn't been a unified, intentional approach to really look at the structure of the AAAs, the supports and services that they might need, and how we can better serve the population through our crucial aging network. The CA 2030 Steering Committee met throughout the course of 2023, really did a lot of great in-depth research and developed a series of recommendations to strengthen and improve the aging network. Out of the recommendations, we've chosen 3 key categories that we're really going to focus on in 2024. The first one is redrawing the planning and service area boundaries. So again, these were established, late 70s, early 80s. There have been several demographic shifts in California since that time. So it is time to kind of like look at the boundaries. Does it make sense the way that they're currently designed? Should we think about restructuring, designing them just based on population changes? A second key area would be the IF formula. So what we call our interstate funding formula. This is a formula that funds the AAAs. We receive money from the Administration for Community Living. We then use this formula, which uses a set of factors to equitably allocate funding to the AAAs, and then at CDA we disperse it to the AAAs. Again, what we really want to focus on and really looking at the if factors are, do they still make sense? Should we make changes? And again, we really, the goal of the formula is to serve the greatest economic and social need. So, based on demographic changes within California, should we consider different weightings for different factors? Should we think about adding additional factors? So our budgets team is currently leading this work and really looking at some different scenarios and possibilities. And then the third area that we're looking at is designation criteria and program offerings by the AAAs. And in this area, what we're really looking at are things like, should we establish core programs? We know that AAAs currently offer certain core programs. Nutrition is offered by everybody, information assistance. Should we specifically call out core programs for a system? And then once we do call out those core programs, should we think about building performance metrics and performance objectives tied to those programs? I think one thing we see with in our program today is, everyone is doing a wonderful job in delivering services, but we really don't have any objective criteria about what high performing or low performing or medium performing means, nor do we, have any specific, target or objectives, at least statewide targets and objectives to drive program performance or looking at program improvements. So that's the goal of that work group. Right now, the way that we're organizing this work is at CDA, we're working with our partner Collaborative Consulting to go through and conduct some research and start thinking about how we structure and design these different efforts. Once we do our design work and come up with some frameworks and structures and scenarios, we'll then be sharing that out with the AAAs and then engaging in conversations. Likely those conversations would happen, during maybe the end of summer, beginning of fall, and would have conversations about, what we may want to go forward with and adopt. The other thing I'll note on CA 2030 is there's currently a Senate bill that I'm sure most of you have heard about, Senate Bill 1249, which is authored by Senator Roth and is being sponsored by the California Commission on Aging. And that Senate bill contains provisions that would be important to implement different aspects of CA 2030. Currently, what the bill, kind of like envisions the state doing is, as I mentioned previously, developing core programs for the AAAs, tying performance metrics and objectives to these core programs, updating the interstate funding formula, conducting a public awareness campaign for aging, which again, I think we commonly say the AAAs and ILCs for that matter are the best kept secrets in California. A lot of great services are offered, but very few people really know about the services or take advantage of them. So really thinking about how we can really heighten the public awareness of AAAs and the services they offer. And then finally, inviting counties to also consider whether they want to operate OA services and programs. That's the components of the bill, the provisions of the bill. It does go through a legislative process, so this will be heard by policy committees. If there's fiscal components of the bill, it may be also referred over to an appropriations committee. So those hearings will be upcoming, and folks will be invited to provide testimony about aspects of this. So basically, our goal really for the course of this year is really to focus on these three areas, develop plans, scenarios, meet with our AAA partners, and then eventually get some operational plans in place to start moving forward with these on these areas. And then the second area I want to update is what we call our no wrong door system. And I presented on the no wrong door system in this committee previously. What the no wrong door system really envisions is a statewide system, and really two key components: a statewide call center and then a interactive web portal where anybody in the state could call up and really in one flick of the screen, one press of the button, see all of the different supports and services that could be available to them for aging and disability programs, and then give them filtering abilities, some research capabilities to really determine what services would really best suit their needs. So that's the interactive web portal. Through a customer contact center, we would even expand those further, where you do maybe an intake with somebody who calls in and you do a brief assessment of what sort of supports and services they need. And then that individual would then do warm referrals or handoffs to the different programs to connect them with services and supports. We kicked off what we call our State Leadership Council for the No Wrong Door system just last week. And our core partners on the State Leadership Council include the Department of Social Services, Department of Developmental Services, Department of Rehabilitation, and Department of Healthcare Services. Really great group. Everyone is really highly engaged, very collaborative. Right now, we're just kind of like calibrating amongst ourselves in terms of how we're defining a no wrong door system, how we see these other departments kind of like interacting with that no wrong door system. And then the next steps will likely be, what will our first actions be? I think some of the things we're currently contemplating is what programs under these departments do we want to form really strong partnerships with, both at the state level and the local level. So, you can think about CalFresh, in-home supportive services, those types of programs. And maybe get some sort of like MOU or an agreement with the state and locals to really form strong partnerships in these areas. And then really coming up with maybe a system of streamlined referrals where, as it is now, an individual could shop around to 5 or different departments to figure out who they should go to or they should talk to. But through a no wrong door system, you could do seamless referrals electronically, and then follow up with the entities to make sure that the services are actually delivered. So we're really excited, and we're really excited that our sister departments are excited. And I think we're going to get a lot of great engagement. We're going to be meeting, at least in this we have like 5 initial meetings scheduled to kind of just get our plans together. And then after that, we really look to operationalize this and actually get some real work done. So probably around October, November is when we think we'll start embarking upon some initial action steps with the no wrong door system. And I'll also say along that, as we're conducting our plans and creating this work, obviously would include our local partners. We can't do this without, AAAs, without ILCs, without the strong collaboration at the state level. We can come up with these concepts, but then we also have to make sure this works for our local partners and providers as well. So those are my updates for today, and happy to take any questions.
Thanks, Mark. I see one question, and I should pull this up. Is that Rita?
It's Rita.
Okay.
Yeah. So, sounds like good stuff going to be happening. Would you say again what the departments are in the no wrong door committee?
Yes, Social Services, Department of Rehabilitation, Department of Developmental Services, and the Department of Healthcare Services, in addition to CDA.
Thank you.
Sure.
Two things on this council. Is somebody taking point? I mean, is somebody like the facilitator amongst the agencies?
Yes, so CDA's role is as administrator of the system, so we're kind of like acting as lead with our partners right now, collaborative consulting, to develop the agendas and to facilitate the discussions. Yeah.
Yeah, at the bottom line, who writes the agenda and gets it around?
Right.
So at this point, it's CDA.
Yes, and I'll note that the leads on this, similar with ADRC, is also Department of Rehabilitation as well. We have the administrative resources to actually, run the meetings, so that's why we're the administrator, but rehab is really our other key partner.
And I guess this is occurring as a set of closed meetings at this point, but
yes,
at some point, this will open up to
absolutely
public view.
Yeah,
because it's a big deal.
It is a big deal.
Yeah.
So I see Kelly and then Rita again.
Oh, sorry, I'll take mine down.
Just had a question about the bill that you mentioned, the SB 1249. Is that the bill? So does that mean that without that legislation passing, then all the changes that you guys are reviewing right now, then we can't take action unless the legislation is passed, or?
No, not at all. Some of this work can be done administratively. I think that the benefit of having an actual bill is it gives a little more, I guess, emphasis or priority to conducting this work. And it really helps you secure legislative backing and administration backing. So, if we need something to point towards to say, this is our plan, this is what we're driving towards, you can always point to the legislation. But, things like creating core programs, have had conversations with C4A about that already. The idea of establishing performance metrics. So yeah, the work is absolutely going to continue.
Okay, and then there's no budget with that yet? There's no budget request that goes with it because we don't know the cost yet?
Correct. We'll have to see. And, mind you, this is the senator who's authoring the bill. If there's amendments made to the bill, those could happen, and there could be amendments that could drive costs. We don't really see any significant costs at this point tied to the bill. But again, depending on amendments, it could drive some costs.
Thank you.
Thank you for the updates, Mark. This is Eli. Really interesting kind of development on the No Wrong Door Advisory Council. And what I'm wondering about with the kind of focus on a state web portal and a state call system or call center. Has there, and hearing you say, obviously there needs to be coordination at the local level. And that, so how does kind of the advisory council see like the local resources that have been developed, whether it's, at the AAA, the ILC, the ADRC, interacting with this, kind of state website and call center?
Yeah, absolutely. And, all of this is in states of development, of course, right?
Yeah.
So right now I'm kind of like speaking to a vision. What happens in the interim could look very different, and this could be very slow moving. But I'll just speak to like the web portal, for instance, initially. So some of you have heard me talk about the CHARM project, which is our effort to re-platform all of the AAAs onto one enterprise client relationship management system. The idea is that the web portal would plug into that. So if somebody goes onto the website, they're searching for resources, they're looking for things in their area, and then they decide, hey, I need help. You could send through the web portal like a request for help. It would go to their AAA. The AAA would then catch the request, respond, call the customer, and then assist them. The state contact center, that's going to be more complicated. First of all, I say state contact center. I can't guarantee that will actually ever materialize, but it's part of a vision. It's what other states have done. So that's why I refer to it that way. That would also tie into the CHARM system. So again, if you call the state, call center and you say, hey, I want help, they do an intake. They then do this process of referrals. they would have the ability to input the referrals into, again, the CHARM system. So that would be caught by the AAA, and then the AAA would respond to the request. So we're seeing it as all being integrated. And that's currently, like, as we're designing CHARM, the kind of interoperability that we're envisioning.
Thank you.
Yeah.
Mark, do you look, I mean, most of our, of the ADRCs are using 211 as an intake.
Yeah.
Are you looking at that possibly replacing that partnership?
I mean, right now, it's so early. I really couldn't say. I mean, there's a lot of different ways you could do this. If we decide that the current, like, contact center providers are very strong and capable, maybe they continue to serve as that intake, right? And it just ties into some sort of a state system. Maybe a 211 decides, hey, I'm providing this great service, I want to expand. Other folks are willing to give up their call centers, maybe could do regional call centers. There's just a lot of different possibilities. So yeah, I mean, at this point, we're not making any decisions about how to construct this. Yeah.
Rita.
So let me just say about having had quite a lot of experience with call centers, that I would recommend that you allow both the 211 system and the state system. Keeping hours of a call center that is available to the public is a little tricky. And it always helps to have a local resource anyway, since people are going to the local resource for other things. So my recommendation to you really strongly is to encourage both to exist at the same time.
Thank you, Rita. Yeah, I definitely know about your experience having worked at large departments, your experience with call centers. Yeah, and I'll just say that the whole call center concept is years in the future. I mean, we really have to get CHARM in place first, which we're looking at maybe a 3-year time horizon for CHARM. So then maybe another 2 years out before you touch that. So it's going to be a while.
Ramon, you have a question?
Yeah, to go back to your first topic, you mentioned working with collaborative consulting on research design. What kinds of questions would they be answering?
So on CA 2030, I don't know that they would be answering questions. It's really getting a lot of research, helping us with research. For instance, conducting, national research on what if factors or what if weightings do other states use, right? Just to inform how we might want to do it. Or, here's some program performance metrics that, say, Virginia uses. You might consider adopting these types of performance measures. Yeah, but they wouldn't be answering questions or, making decisions. That's all on us. They're really just our research.
And then the other thing was you mentioned changing demographics.
Yeah.
And I was wondering what demographics are changing: age, gender,
All of
ethnicity?
the above: age, gender, ethnicity. Yeah, I mean, income, right? There's just, I mean, you've probably seen a lot of
Housing, I guess,
data.
at this point.
Housing, right? I mean, all of the above. And so that's a lot of what we look at is where the population shifts, where are the greatest percentage of older adults today, where will they be 10 years from now? So yeah, we're going to look at all of that.
Thanks. Joe, I see your hand up.
Yeah, thank you. Mark, with the AAA, the 2030, potentially redrawing boundaries, and I might be a little ahead of myself, but with the current relationships with AAAs and ADRCs, has there been thought how that might affect the current ADRCs, contracts, things in place, MOUs? And again, might be a little early for it, but I think it's pertinent to this committee. Thank you.
Oh, no, absolutely, Joe. And that is something that we're very mindful of as we go through this. We've started creating maps of, here's the ILC map, and then here's the AAA map, and here's like the ADRC partnerships and how do all of these overlay on one another. So if there is any conversation about boundaries, we'll absolutely say, okay, how's this going to affect the current relationships? And do those relationships need to be undone or redone? So yeah, we're very sensitive to all of that. And like I say, before we take any action on any maps, there's going to be a conversation among all of us to make sure that we're capturing all the considerations and factors.
I also see in the chat that Maggie has a question.
Are you referring to me, Maggie Kraft?
Yes, I am, Maggie, sorry.
Thank you. Hi, everybody. Thank you. I am the AAA director in PSA 1, Humboldt, Delaware County. And I have two questions. One is in terms of when you talk about redrawing boundaries, you often talk about due to population changes. So I guess my question is this idea that those boundaries should be drawn to more effectively kind of even out the populations that are in each PSA. I'm missing what the specific connection to boundaries and population, what that connection is specifically. I mean, I can think of all kinds of reasons to potentially draw them. Your example of trying to match independent living and things like that. But how is that focus on the population being the focus? And then the other question is that you're talking about SB 1249, and I know that right now the only thing in that bill is the piece about inviting counties to consider if they want to offer the services. All the other pieces you mentioned, none of that language is in the bills yet. So I'm curious when that language will be there, and also when there will be clarification or be thinking about what would happen in a multi-county PSA if one county might say, yeah, we want to do it, but the other 4 or 7 or 2 or whatever counties say, no, we don't want to do it. So I'm just so sorry. Those are 3 questions. And I hope you're taking good notes, Mark. Sorry.
Yeah, no. So on the first one, when it comes to redrawing boundaries based on demographics, I think it's really just investigating the relationship of scale to performance or scale to service. So if you have, like, say, a PSA that has a really high population of older adults, should that stay as 1 PSA? Should it be 2 PSAs? I mean, I think those are the kind of questions that we're thinking about. And, what sort of services and supports really exist within a current jurisdiction? Is that enough to support the population? Do those need to be expanded? And could that be helped if you expanded a PSA boundary or if you reduced a PSA boundary? So I think that's it. Like I say, we haven't made any set criteria yet in terms of, how to look at the boundaries, but those are just some questions. And as we look at, whether boundaries should be redrawn, those are the kind of factors I would look at. The second one, which has to do with the bill, the latest version I saw of the bill did include all of those components. I don't know if something got amended out or whether there's an earlier version of the bill. But I can definitely follow up with everybody. But yes. And then on the final one, in terms of like JPAs and how those might be affected, again, I think it's a little premature to have those discussions. I mean, definitely we would want to know if this bill proceeds as is and counties elect to say, operate AAAs or certain programs, what that would do to the existing relationships and how those would have to be redone. But yeah, I mean, those are just all things that we would have discussions on. I can't really speak to it at this point.
Thank you.
Reed, is your hand up again?
Yeah, Mark, I really appreciate your talking to people about this early and indicating that there's going to be stakeholders involved, because I think this is going to make a lot of people very nervous, anxious about what changes this is going to make. So if you could provide a timeline, I think that would be helpful.
Yeah, I mean, we will definitely be providing a timeline on, at least internal department efforts to move these different components forward. In terms of a timeline for the legislation, that's really hard. I mean, all of the hearings will be published, and whether the legislature, holds the bill or moves forward with the bill, that will all dictate the timing around the actual legislation.
Can I ask? It's just an observation. I'm a JPA, right? I have two counties.
Yeah.
I can see, based on conversations that we've had, so just for consideration, I can see my smaller county saying, we don't want this. We want to keep it the way it is, but my bigger county saying, we don't want to have to deal with this.
Right.
So, it's kind of the reverse of, yeah, we want one. And I'm anxious to see what that might look like in your, how CD is in their considerations long-term.
Yeah, and that'll be another scenario. I mean, it's interesting because, we think about, say a provider currently holds it and the county says, I would like to operate the AAA from now on, that. And if it's just like one PSA, one jurisdiction, that's a lot more straightforward. Something like this where you might have two counties with like opposing views or different views about breaking up a partnership. Yeah, I mean, again, we're trying to track every sort of like different scenario that could occur. But I can't really speak to how that might play out or how, and a lot of it might be very localized in terms of like specific relationships, and maybe negotiations can happen, things can be brokered. Sometimes they can't, so.
Yeah.
Yeah.
That was a reverse of what I think a lot of people are thinking.
Right, it's an interesting scenario.
So Joe, I thought I saw your hand up, but it's down.
Oh, yeah, I'm sorry, I did. Hey, just maybe one final question on it. Again, I know there's a lot and there's a long way to go, but in terms of however the lines get drawn, whoever might want to apply for it, I think one of the issues that is gonna need to get addressed sooner rather than later is that you currently have AAAs that are designated. And I think if there was a change, that you would have to de-designate them. And so there's a whole slew of stuff goes on with that. The new ACL rules actually got fairly specific on de-designation process. And basically, ensuring that everyone has an opportunity to comment. So anyway, just want to throw that out there, add to the mix, but thanks for presenting today.
Oh, absolutely. Yeah. And that issue about de-designation is something else that, we're following and tracking within CDA as well.
Any other questions? Mark, thank you. Appreciate it.
So we're gonna move to partner updates from our ex officios. And we're gonna shift the order a little bit due to scheduling. So first, we'd like to call upon the State Council for Independent Living. And just each partner will have about 5 minutes to provide their update. So I believe it's Allison with Silk.
Hi, yes, everyone. This is Allison Viramontes Anon. Sorry I wasn't able to be on a little bit earlier. I will be very brief. So I just wanted to let everyone know we are fully constituted at the Silk, but we do anticipate some openings in September. We're looking for people with disabilities who are not employed by an ILC or state agency and would be willing to attend meetings with or without accommodations virtually and in person, as well as to engage in the work of the council. So if you are interested, please feel free to reach out to myself or Carrie, and we can help get started in the consideration application process. Applicants must be 18 years or older to serve on the Silk, and we are hoping to have those applications to the governor's office by the end of July. Additionally, as part of our current spill, the IL definitions or independent living definitions work group has been creating a definitions guide that will be used by all partners in the California Independent Living Network. The definitions group sent the draft out for public comment, and they hope to have a guide ready for implementation by the beginning of September. And there will be another opportunity to comment before we finalize this project. The Silk is right now primarily focused on the development of the next 3-year spill for fiscal year 2025, 2026, and 2027. We have a draft with draft goals that we shared during our March full council meeting last week, but nothing has been finalized and funding has not yet been discussed or decided. Once this bill has been finalized, the SILC will seek public input through a public hearing process, and we plan for this to occur in April. The public hearings will be held virtually with in-person locations in Southern California, as well as Northern California. Lastly, the next full council meeting will be on June 5th and 6th and will be held virtually. We hope to hold our September meeting in person in Sacramento, and that is scheduled for September 17th and 18th. But that is all I have for you guys today. Thank you.
Thank you so much, Allison. So now we're gonna go to the top of the order. The California Association of Areas for Aging, and Michael. You are available, Michael Casca. Okay, all right. How about Department of Veterans Affairs, CalVet? I believe I heard Sean earlier.
Hello there, I'm here. I just want to give a quick update to the committee on a grant that we grant funds that we awarded last year. We put a competitive NOFA out late 2022, and last year we granted we made 6 grants with that $20 million that we had. 6 grants around the state, one in the Inland Empire, one in Los Angeles, one serving the Sacramento area, one serving the Sonoma Northern Coast area, one in San Diego, and one serving San Francisco Bay Area. The purpose of the grants, we call the pilot program the Veteran Support to Self-Reliance Pilot, the purpose of which is to support operators and service providers at permanent supportive housing sites to enhance the services that they provide to veterans who are aging and who have high score in acuity testing. And so the pilot has been progressing well. We've had a lot of feedback in terms of the different various models that we're supporting, and obviously the models are aimed at getting at those health-related service needs that go sort of over and beyond what the services that veterans in permanent supportive housing receive currently. Especially those who are aging and really at high risk of entering or requiring assisted living type of care. The idea is to sort of find out where the service needs, where those service needs are right-sized in order to prevent that need and allow veterans to age in place in their community setting. And so we've had the 6 grantees report a lot of successes and challenges, many of which is staffing and retaining staffing. We've had some ebbs and flows in that area, but we're still going on. It's a 3-year pilot, so we're in the middle of observing, and we're looking forward to seeing how everything goes over the course, and we'll be providing some evaluation and some documentation on it afterwards. Thank you.
Thank you so much, Sean. Next up, we have California Commission on Aging, Carol. Carol, are you? She expressed.
Carol, are you there?
Oh, okay. Rita, you're doing the report?
No, I'm looking for Carol. I'm surprised she's not here.
All right, yeah, I guess okay. All right, we'll try to come back to CCOA at the end of Carol.
Thank you.
We know that CFILC is not here today. And Department of Developmental Services did their report. So we are gonna skip down to Department of Healthcare Services.
Hello, everyone. Sorry for the really scratchy voice. I'm losing my voice. But as I mentioned earlier, I'm Liz Jacobs-Ware, and I'm serving as the section chief in the Home and Community-Based Services branch. And really our only update for today is our new team members. So myself being one of them, and then we also have Dewey, who's attended a number of these meetings, And Jerry Wilson, I think this is her first or second meeting. So just wanted to let you all know that we'll be attending from now on. And that's it for us.
Thank you so much. So next we have Department of Rehabilitation. And I believe Anna had to step away. And so Regina, if you are available.
Sure. Hi, everyone. Thank you. And I will be providing the update for Department of Rehabilitation. And so to begin with, an update on our Chief Deputy Director, Victor Duran. He has been redirected for 12 months at 0.75 FTE of his time. He is going to be the project director for the Master Plan on Developmental Services. And this master plan will seek to create and strengthen bridges that connect the developmental services system to other critical systems throughout California's Health and Human Services Agency and other systems and services, including education, housing, employment, transportation, and safety. So he will be doing that for 0.75 of his time. His 0.25 of his time, he'll be at Department of Rehabilitation, but please note that we have other executive staff stepping in for his position while he is redirected. And then the department is also working on the master plan on career education. And this plan will increase equitable access to living wage jobs by creating and strengthening educational and training pathways that are specific to sectors, regions, and individual skills and experiences. And then also for our department, we have had a return to on-site work. For the past 4 years, we have been primarily working teleworking, and now we are reporting to on-site work 2 days a week. This has been a change, but it's been pretty good for our bringing back. It's been great for our department just to bring staff back and meeting in person. It's much different than meeting in Zoom, and it's great to reconnect and see all the friendly faces around the office again. And on our independent living and assistive technology section, the independent living section, we are hiring for a manager. So for manager 1, they'll oversee the grant administrators and the work of the department with our independent living centers. This position is posted on the CalJobs website, and the final filing date is this Sunday. So that is on March 17th. And for our independent living side, we have great work. In 2024, we are planning site visits with all 28 independent living centers. And so these site visits will be conducted by the grant administrator and myself. So we are looking forward to, we say it's the world tour, even though it's just of California, but we do say it is going to be quite a tour. So it's going to be great to connect with all the centers again. And for our traumatic brain injury grant, we are releasing the request for application on April 5th. Our TBI state funded grants were, this last past grant cycle were only, we had 6 providers. This time we have the RFA is for a total of 12 providers. Since we had the home and community-based services contracts, we really wanted to, that are ending June 30th, we really wanted to look at other funds for securing more funds for the TBI state funded grant, which is continuous, and we are able to do so. So we are now going to be awarding up to 12 providers, and there is also an increase of funds per year. Currently, the state funded TBI grants are funded at $175,000 a year, and that increase is now up to $300,000 per year. And that is it for our department's updates. I'm happy to take any questions.
Thank you so much, Regina. Any questions? Not seeing any.
Okay.
So now we're going to go back to the Commission on Aging. And I believe, Rita, you are ready to give that report.
Yeah, I am. So the next CCOA general meeting is March 18th from 1 to 5. On March 19th, the commissioners and the staff will be conducting legislative visits to the Capitol. We have 4 sponsored bills: AB 1993 Cholera, Residential Facilities for the Elderly; AB 2207, State Boards and Commissions having older adults on particular boards to ensure representation; AB 2620, revision of the structure of the California Commission on Aging, including, I hope, a return to a reasonable amount of commissioners. We currently have, I think, 18, and we never have them filled, so we're asking for a number of changes. Also, we have SB 1249, the Mellow Granlund Older Californians Act. An overview of all 4 bills is available on the CCOA website under the Advocacy tab, and we appreciate whatever support. Thank you. Also, save the date for CCOA's 50th anniversary gala on June 26th from 5 to 9 in Sacramento. Tickets will go on sale mid-April. See all your old cronies and some of your young cronies. Tickets will go on sale mid-April. Anyone interested in sponsoring the event, please contact CCOA and click on the Get Loud, Celebrate Aging for All Californians link. That's it.
Awesome. Love it. Get loud. I believe we've heard from all of our partners who are here. Unless anyone joined that has not given their report. And I don't see or hear anyone. So I think we're ready to move to our next item.
Okay, next up is partner updates. So any of the advisory committee members who want to provide any additional updates, go ahead and raise your hand. Let us know. Oh, Kelly.
Hi, thank you. This is Kelly from Alzheimer's LA. I just wanted to share that our bill AB 2541, sponsored by Assemblymember Dr. Baines, it will be heard in the Assembly Public Safety Committee on consent on Tuesday. And this bill would direct post to update guidelines to address wandering for those with a cognitive impairment, including those with autism, Alzheimer's, and other dementias. So we welcome everyone's support, and I have support letters and template letters and action items for individuals as well, and I can send those to Wilson. Thank you.
Thanks, Kelly. Ramon.
Could you repeat the bill number?
That's AB 2541.
Thank you. Any other updates? Okay. Seeing no hands, we move to the next item.
And our next item is public comment. So our last opportunity for members of the public to comment on any of the items we've covered in the second half of the meeting. Any hands on the Zoom? Not seeing any. Okay. Back to you, Cindy.
Okay, next up, summary of the action items, which I always look at Wilson because he takes better notes than I do.
Wilson from CDA. So I only have one follow-up item to note, and it's sending out ACL or Christy Galensi's presentation, the web links she was referring to, and other resource materials. Anything else? Yes.
I think that was it.
Easy enough.
All right, so we are on to future meeting dates and agenda items. So our next meeting is scheduled for May 17th, assuming that's going to be here at the CDA office, Sacramento. And a question for the committee. Any input or thoughts on future agenda items that they would like to see? Any thoughts, either in the room or on the Zoom?
The only thing that I would say is that whoever has been selecting these has been doing a fabulous job, because each of these presentations is really valuable and educational.
Well, all the credit goes to Cindy and I, so we'll take it. No, I mean, it's team effort.
It is team.
Team effort. Yes, Ramon.
I was just gonna ask, can we get an update on this 5-agency group that is working on the no wrong door? Because
The no
I
wrong
assume by then there will have been another meeting.
Yes.
Maybe some progress.
Definitely.
Yeah, that's great.
Yeah. And I will add a suggestion. I know it's very early in its development, but the master plan on developmental disability is really important. We've talked about at the ADRC how we need to be more inclusive of individuals with IDD. So it would be great to have an update from the leadership of the MPADD at a future meeting. Yes.
Also, by then, we'll know what the budget really is.
There you go.
And how that affects all the, related programs that this committee touches. It'd be good to find out how we did.
I'll volunteer. I think, CDA, we could probably do an update on the data strategies work that is underway. That will help all of our programs, through the charm systems.
Okay.
Great. We got some good suggested items. Anything else?
One of the things that has just come out is the shrink the shortfall document from the legislature. So that might be something that everybody wants to take a look at.
What is that document?
It's called shrink. Oh, now I'm gonna have trouble finding it. I just had it. It's
Budget shortfall?
it's shrink the budget for it's like shrink the shortfall.
Got it.
It's coming out of the legislature. It just came out a little while ago. Shrink the shortfall. So it's do you remember those those documents they used to send out about how they were gonna save parts of the budget? That I think it came from the Senate Budget Committee. So now they're looking at, what are we gonna do to handle the shortfall? And the document just came out today. Hold on just a second.
Are we on it?
Let's see, what is it called? It's called Senate Shrink the Shortfall, Step 1. I'm gonna send it to Wilson.
Okay, any other thoughts, suggestions? All right, not seeing any or hearing any. I think we're ready to close here.
We are ready to close. So can I have a motion?
I move that we close our meeting.
So all in favor?
Aye.
Opposed? Oh, wait. Andrea, was that a question or was that an aye?
It was an aye. I'm here.
It's good to see everybody.
So thank you all. It was a great meeting. Appreciate it. And the meeting is officially over.
Okay. Bye.
So, oh wait. Kinda official.